Thank you so much for inviting me to come and chat to you about the work we've been doing in Cambridge and the potential places for interface between the kind of great work you're doing here with the registries and the more academic work that we're doing at Cambridge. In Cambridge, I have two roles really. One is in the Psychometric Centre, which is a group that spans different academic centres, and there I'm Director of Health Assessment and Innovation. And I'm also, in my research role, a National Institute for Health Research Fellow at the Cambridge Centre for Health Services Research, interested in applying and implementing computer adaptive technologies into primary care primarily to improve patient care. Today I'm going to introduce a few concepts that might have been covered in the previous presentation on patient-reported outcome measures, patient-reported experience measures, and some basics about psychometric theory and psychometric practice. The bulk of my talk will be about new forms of testing, using computer adaptive testing, putting predictions into tests and using feedback to patients and clinicians to increase the effectiveness of interventions of PROMs and increase people's engagement. I'll introduce you some ideas of machine learning and how machine learning is interfacing with psychometrics currently to provide more information from patient outcomes. And I'll also demonstrate our state-of-the-art software called Concerto, which is a free and open source software for making these modern patient assessments on the web. So as I'm sure you're aware, patient-reported outcome and experience measures are basically any measure, usually a questionnaire, that elicits the experience from the patient's perspective without any kind of intervention or interpretation from the clinician. Outcomes generally related to medical outcomes and experiences of things like services. Psychometrics is a name given to the science that underlies patient-reported outcome measures, so it's something we focus on very much in Cambridge, and I'll talk to you today about how previously the kind of psychometrics has been kept rather separate from the clinical practice and how we're trying to integrate that more tightly now. Item response theory is a probabilistic type of psychometric assessment. It was developed in the 1960s and has been becoming more and more popular. It's the standard in educational assessment, but with the PROMIS initiative is becoming much more the standard also in medical health research. Item banks refer to large banks of items like a questionnaire. E-health is any kind of health technology that is electronic or internet based. I'll talk to you in more depth about machine learning and computer adaptive testing. But the point really was that these 5 things shown at the bottom of this slide, I kind of group them together and sometimes refer to them as e-psychometrics. I kind of refer to the most cutting edge thinking really in psychometrics and that will give us the best benefit in terms of patient-based assessments. So just to give you a very selective history of psychometric testing until this point, I suppose the first instance was in the Xia dynasty in China, where generals in the army were assessed using an intelligence test once every 3 years. And then not much changed really until Cattle set up the first psychometric laboratory at the Cavendish lab at Cambridge University, which eventually fell into disrepute with their work on eugenics. In the 1950s, the first patient-reported outcome measures were produced, mainly for things like depression and cognitive ability. And in the 1960s, there was this step jump in psychometric theory when academics like Georg Rasch described item response theory. In 2007, the PROMIS initiative was funded by the National Institute of Health in the United States, and in 2007 we released the in 2011 we released the Concerto platform and also did some pioneering work that I'll talk about later called the My Personality study. And I think what's important to kind of notice, although it seems like here in Sweden we're already moving past this, but the kind of relevant technologies related to PROMs haven't changed very much for 4,000 years. And then until just very recently, there's been an exponential increase in very relevant technologies like electronic health records, APIs that allow databases and websites to talk much more easily with one another, social media and smartphones. So we're really kind of in the right place at the right time to drive a kind of e-health way of thinking about these sort of things. So PROMs and PREMs have been around since the 1950s, more or less. There are thousands available. They're suitable for use in diverse conditions. I think what was covered in the previous presentation was that they're so diverse that sometimes it's quite difficult to compare between the two. So you can have a quality of life scale for multiple sclerosis and a quality of life scale for stroke, and it'd be quite difficult to combine the results, and this is what some of the good promise work has been trying to address. There's plenty of applications for PROMs, for trials, for clinical practice, for audit and assessment. They're great because they're patient-centered, but so my work that focuses mainly on clinical practice has found that they're used in a very ad hoc fashion. It just tends to be a very motivated clinician that would bring them into practice, certainly in the UK. Problematically with the paper-based formats is that they can take a long time to administer and even longer time to score and then interpret and to kind of make sense of what that score and to link it to specific clinical action. So there's not much incentive sometimes for people, for clinicians to use these as tools in their clinical practice, but the systematic review of the evidence suggests that doing so can have a good impact on processes and a good impact on outcomes. Obviously these studies are difficult to do because of the heterogeneity of the intervention. So what seems to work is, in clinical practice at least, is that specific PROMs training and very supported implementation that contains good feedback that's well aligned with practice, and the information can be easily integrated into the available systems and withdrawn when necessary, and that the feedback should be formalized, structured and related to feedback processes as much as possible. Well, one interesting, I think, under-considered aspect of PROMs is how much patients like doing them, that they feel that it means clinicians are taking their issues seriously, that there's kind of a longitudinal follow-up about how they're feeling themselves, and it's kind of a move away from the paternalistic model of medical care. So we're currently working on a Cochrane review to kind of update this evidence, which should hopefully be out towards the end of this year or the start of next year in terms of a clinical intervention. So at Cambridge at CCHSR, we've just finished a 5-year programme grant looking at the General Practice Patient Survey, which is a large survey of people's experiences of general practice services that is sent out annually to something like 5 million people. It's used for monitoring and inspection, it's not used for clinical practice. So we found some interesting things with this, which I think are salient and applicable across patient experience measures, certainly in the UK and potentially in Sweden too. So here's an example question that asks the patient to say, how would you rate your GP for taking your problems seriously? Now, unsurprisingly, or perhaps a little bit surprisingly, most people would say that their GP was good or very good. People tended to be quite reluctant to say things weren't good. And we kind of had this feeling that this wasn't really correlating with what people were saying. So we asked people who had ticked the good category the same question face to face. And these were the sort of responses they were saying. So although they had said good on the questionnaire, the response to the open text was, taking your problem seriously? No, he didn't. Or no, he didn't listen to me. So we seem to have identified an effect using patient experience measures that people are very unwilling to report negatively using a questionnaire. And I'll sort of talk to you a little bit later about the things we're trying to do to kind of overcome this bias that appears to be occurring. Okay. So in terms of improving measurement in clinical practice, we're trying to tackle the barriers to make measurement more efficient, to engage patients and clinicians more by providing instant feedback that's salient to both groups, and to align that feedback more closely with care so clinicians know exactly how to respond to a certain score that comes back off of PROM, and also working on ways to kind of make sense of open text feedback so we're not just collecting this and not using it. It seems like it can give us a better idea of what's happening in terms of patient experience. So the hypothesis for this work is this is all possible using e-psychometrics, and for the rest of the talk today I'll show you the studies we've been conducting over the past year or so that kind of provide evidence to support that hypothesis. In theory, I believe that e-psychometrics can also help transform clinical trials and comparative research, and moving towards patient-centered big data analytics, so using PROMs, but also using things like social media data or other bits of information and digital footprint that are left over by people's interactions online. And we can transform, essentially, I think, patient experience measurements, so we're not left with this sort of bias where someone has to say quite outright that they think their clinician isn't good, even though that's what they actually think. So psychometrics is the science that underlies all these questionnaires. A questionnaire without a kind of psychometric support it really ought not to be used for measuring anyone individually, or for comparing people, or for measuring one person over time. It's split typically into two schools of thought, of item response theory, which is a kind of probabilistic understanding to the way people respond to questionnaires, and classical test theory that people tend to be more familiar with. And I'll try and explain the difference between the two just on one slide. We'll see if this works. Okay, so here is a depression scale that I kind of just made up myself that has 7 items, and you can respond agree or disagree to each item. Under classical test theory, this is how the scoring would work, and as many things you agreed to would be your score out of the scale. The maximum score would be 7, the minimum score would be 0. Somewhere between 0 and 7 we decide there was a clinical cutoff. Now this gives each item equal weighting in terms of what it means to the underlying depression construct, which is not the way we do things in item response theory. In item response theory, we assign each item a value that represents the amount of underlying depression that they measure. So here we have the question, I feel like committing suicide, has a much higher level of theta than does the question, some days I feel like I'm unhappy. Because if you affirm this question, this means something quite significantly more about your underlying level of depression than just saying some days I feel unhappy, which is common and almost ubiquitous. And we can plot this on a normally distributed population graph. So this is what the level of depression might look like for any general population. And we can say that the some days I feel unhappy question is down here. The things won't get better question is a bit higher up because it represents a higher level of depression. And the suicidality question is very high up because you need to be very depressed really to affirm that. And that's the entire theory behind item response theory. And I think it's quite clear to see why that is superior in this way, and we can work out the cutoff using these means. But what's also really important about item response theory is we don't need to use every question in the scale because we know what each question means. So imagine a case where a patient hadn't filled out the first 4 questions but had filled out the final 3. Then using classical test theory, we would have to estimate their score as being 3 out of 7. We might say that's below the cutoff for depression, but there's a caveat, there's a lot of missing data. Essentially that assessment is wasted. Under item response theory, we can get an accurate estimate and we can understand just how accurate our estimate is. And it's this ability to kind of just use and pick and choose different items that allows computer adaptive testing to be possible, allows flexible item banks to be possible. Okay. So I promised I would try and explain a little bit about the RASH model and the graded response model because it's been quite a tribalistic thing occurring between these two different types of item response theories since the 1960s. So the only reason I've put an equation up is not to kind of make anyone feel bad, but just to show you the only difference between the two mathematically is the inclusion of the discrimination parameter here. So you can very simply, very straightforwardly see that there's not much difference between these two models mathematically. The RASH model has slightly stricter assumptions. It leads to shorter tests that are theoretically better. And thus might be more suitable for pencil and paper tests that you want to be as short as possible. The graded response model has slightly relaxed assumptions, which allows more items to be retained in the item bank, so the item banks become longer. And therefore it might be more suitable for computer administration, where you can keep a broader type of concept. And what I always try and remember is that the correlation between the scores on both of these models is exceptionally high. So there's good arguments one way or another way, but I think my personal belief is that I'd much rather see these things implemented at scale rather than kind of discuss which one is better all the time. Okay. So just in summary, item response theory is a probabilistic psychometric theory. The basic premise is the more of an underlying construct you have, the more likely you are to agree to an item that measures it. It allows tests to be sample-free and test-free in some circumstances, and it gives you an individual reliability estimate, and you can use any combination of items. And because of that, it permits computer adaptive testing, and I'll show you a study today where it also allows you to predict what people would have said to items that haven't been seen yet with quite high accuracy. Okay, so I suppose the cutting edge at the moment in terms of psychometric analysis in health services research really has been dictated by the PROMIS group in this, outlined in this paper by Bryce Reeve in Medical Care in 2007. And this is the protocol that we still follow now. It produces very good item banks, very strong computer adaptive tests, and I'll show you some of the evidence for that today. Okay, so that's really the role of PROMIS and how they've contributed to the theory. So I'd like to talk a little bit about the Psychometric Centre where I work in Cambridge. It's a really broad church of psychometricians, psychologists, computer scientists, people who are interested in educational assessment, personality assessment, cognitive assessment, and health assessment. And really, we're very aware that kind of over the past 60 or so years, particularly in medicine, psychometrics has sort of been split into two camps. One who are the epidemiologists, typically, who are very interested in cutting-edge science and the maths and the technology that underlay it, and the clinicians or the kind of auditors or the services who are more interested in getting things implemented and giving assessment and feedback on the services they were providing. And the communication, as far as I've seen, between the two has, until very recently, been rather poor. So what we're really interested in doing is at all stages of this kind of psychometric process, providing research to support things, leadership, innovation through new products and new techniques, and the support for people to use those new products and new techniques in a way that satisfies both the most rigorous scientific standards and also the most straightforward means of implementation. So today I'm going to talk about three specific technologies that I suppose may be considered cutting edge. Three techniques, and one technology that we've kind of created that allows all of these techniques to be implemented in tests. So firstly, I'm going to talk about computer adaptive testing, which I'm sure you're aware of, that is designed to improve the efficiency and the precision of tests. I'm going to talk about a novel study looking at prediction and feedback, which allows us to validate our computer adaptive tests in practice and perhaps also increase people's engagement with the testing process, which is a very important thing, I think. And then I'm going to talk about a machine learning study I conducted recently, trying to make sense of new forms of data, so how we can move away from just questionnaires into things like open text, perhaps even pictures or digital footprint online. So in the first study, I developed a computer adaptive test for the WHO quality of life measure. Computer adaptive testing is basically a computer system which iteratively learns about the person taking the test and only asks people the most informative and relevant question based on their previous responses. It's underlain by item response theory, and it's generally shown that it can make tests more efficient, more reliable, and better targeted. It's pretty widely used in educational assessment and very high-stakes educational assessments in the USA, the college leaving exams and the graduate management exams certainly use CAT. And hopefully it'll be more and more used in health services research and audit, because I think there's plenty of things other than the efficiency and the reliability that could really benefit people. So this is how a computer adaptive test works. You have three constituent parts, I suppose. You have your item bank full of items. You have your cat in the middle, who has all the algorithms and can do the kind of thinking for you. And you have your participant. So you begin the test, and the cat considers which is the best item to administer, and it gives it to the participant, who sends back her response. Then the cat does a little bit of thinking, and it works out the estimate of a person's quality of life in this case, and it gives a reliability value based on how many questions have been answered. And it continues this process. It chooses the next best item based on that, and it sends it round, and then it updates its quality of life estimate, and the reliability gets a bit greater because it's more certain about its estimate. And this continues until the reliability has reached a point that we've predefined as being acceptable. So in this case, good enough for clinical practice, possibly. So the advantage of what we can see here is that we had an 8-item item bank, and the cat has only had to administer 4 of these items, which is a common case in practice. So the efficiency is a good thing, and it's obviously saving people time, particularly if you can do it at scale. So if you can ask people half the number of questions in a national survey that asked millions of people, then you can save many, many years of people's time per year. Another important thing about computer adaptive testing that we've sort of thought about but haven't really rigorously evaluated yet is its ability to only show the most relevant questions to certain people. So this is a patient living with motor neuron disease or amyotrophic lateral sclerosis who is obviously very reliant on assistive technologies to live his day-to-day life. It's very important for patients with ALS, MND, that their functional impairment is monitored closely. But you can imagine that as soon as someone is diagnosed, the clinician is reluctant perhaps to give them the questionnaire that will undoubtedly ask questions about giving up personal care, inability to breathe, and difficulty to swallow. So perhaps we're missing some of these early data points, or we're giving people questionnaires and they're becoming unnecessarily distressed by looking and gaining a sort of grim picture of what's happening in the future. And computer adaptive testing is, in theory, although perhaps not quite yet in practice, eminently able to protect patients like this by not showing them questions that are irrelevant to their current stage of disease. This is something that people have taken on in educational assessments because no one likes asking questions that are far too hard or far too easy for them. So in educational assessments, you just keep on asking questions that are at a nice level of difficulty. And I think we can really harness that to improve assessment and patient quality of life through assessment in the health services. So back to the WHO-QoL measure. So the WHO-QoL measure is a multidimensional measure of global quality of life, developed across 15 field centres, available in plenty of languages. And it measures quality of life in 4 distinct domains of physical, psychological, social, and environmental quality of life. I developed the item bank using a UK sample because there were some problems using the entire international sample. And as I said, it used rash analysis. And as I said before, rash is quite strict. So we ended up losing a lot of the items because they weren't kind of fitting with the assumptions of the model. So we left up with 11 items per bank instead of 25 or so. And the banks were suitable for patients with long-term conditions. Essentially, the results of this study showed that the WHO-QoL can be made to be 82% shorter and more reliable by applying both item response theory and computer adaptive testing. So in my own research, where I've collected about 3,000 people's data online, that translates to about a 2-day saving of people's time. And as I mentioned before, if we applied this same sort of efficiency in the United Kingdom to the general patient practice survey, we could save 100 years of patient time every year simply by making questionnaires shorter and doing so without any loss to reliability, and also potentially improving the experience of measurement by restricting irrelevant or upsetting items from people. We conducted a second study that found that these CAT assessments are accurate and they can be made comparable between countries. So there was initially some problems with different countries experiencing quality of life in different ways, but they could be accounted for statistically. And what's important really about this second finding is that although it used countries in this example, we could also do this with disease groups. So we could have questionnaires that have some of the same questions, but some different questions that provide a directly comparable metric between 2 conditions and allow for the first time both disease-specific and also generic measurement using this technique. So this is what the computer adaptive test looked like. It was developed on Concerto, which is the software that I'll demonstrate later on today. It had graphical feedback that obviously changed with the scores, and also text feedback that changed with the scores, and included some guidance for the patient if they needed to, or the person taking the test, if they needed to seek additional services in each of those domains. So once we developed a CAT, generally the standard thing to do when you're developing CAT is to test it using simulations in a lab. And it's very difficult to kind of assess whether a CAT's working in practice. It really ought to, and it's not often that you see sort of evidence that these techniques don't work, but I wanted to think of a way that we we could kind of do that more accurately and in an engaging way. So I designed the study called Predictions in a Computer Adaptive Testing Environment, Predicate, and the idea was to assess the validity in the real world. Basically what happened is someone completed the CAT until the stopping rule is met. We have enough information about the person and then it stops. And then a new algorithm predicts what people would have said to questions that haven't yet been asked. And the test takers are then allowed to rate the predictions and say whether they were correct, whether they were close, or whether they were wrong. So this is what the additional modules sort of look like. We ended up getting 700 people completing it from all around the world really, and 173 people from the UK, a good average age and a very slight preponderance of men in the sample. There were 50 patients with long-term conditions, which is also encouraging. So we found in the UK sample that people said on average 94% of the time that the prediction was either right or it was close. It was exactly right 69% of the time, which was within 10% of our predicted accuracy. Close but not quite right, 25% of the time, and the prediction was outright wrong only 6% of the time. Encouragingly, for the use of this as a kind of predictive technology, a validation technology, it was wrong more in samples where the item bank wasn't developed. So this is one way of doing this thing, that you can allow people to kind of get engaged with the test and say, we think we know what you're going to say, what do you think? And that appears to improve people's engagement. But what can also happen with a CAT is because you ask fewer questions, you might be losing some clinical information. So this algorithm could also backfill unanswered questionnaires and allow clinicians to see that, you know, this question wasn't asked, but there's a 70% chance that they would have agreed to it, which might be useful going forward in clinical practice. So just to conclude, the item bank is brief. It can be administered in 120 seconds. The published estimate for the amount of time it takes to complete the WHO 100 is half an hour, although I think that's probably quite a long estimate. And it's as much as an 82% increase in the efficiency compared to the paper-based versions. The simulations translated well to the real-world computer adaptive test, which appeared to be well received. And the prediction study supports the validity of the measurement. A lot of people give a lot of feedback on the feedback they receive from the test and say that they really enjoy that, that it helped them think about themselves and their condition and their illness and their relation to other people in the country. I'm not sure if that's something that you guys do with your current measures on the EQ5D and thing. And people really liked the predictions. They thought it was something quite cool that we could kind of guess what they were going to say with reasonable accuracy. So this leads me to the kind of third study we've done this year, which was to try and tackle really the free text issue. And this is using machine learning algorithms to make sense of GP performance data. So in the UK, generally when we do a large national scale questionnaire survey, we include some space for open text information at the end. And the rationale for that, I think, is sensible. It's because we might lose some important information that we didn't capture in the questionnaire. But in the reality, these are collected in the millions and they're never used, because to get a qualitative analyst to go through all these things is time-consuming and very expensive. And there are also plenty of other places where people are leaving bits of signals about their experience with services. These are some tweets I made up. Which we could potentially also apply algorithms to learn more about the experience of our health services. Okay, so in this study we worked with the General Medical Council, and there was 548 doctors for whom we invited 360-degree feedback from all their colleagues. We ended up getting a 20-item questionnaire for each of the doctors and 1,600 comments from their colleagues describing their work performance in free text information written in the questionnaire. And what we wanted to do was apply machine learning to the open text comments to see if we could make sense of them, to see if there was a feasibility to kind of do this at scale and gain some more important insight, potentially identify any safety or improvement issues automatically and at scale. So machine learning is something that's really kind of taking off at the moment. I'm not sure if it's something you're kind of very aware of, but all of these services make very heavy use of machine learning. It's the reason that your phone works so well, the predictive texting in your phone, that your phone understands where you should go and all this sort of thing is due to very heavy investment in machine learning. And it's tricky to do in health services because if you have anyone with the requisite skills, then they're immediately sort of transferred to California to work for one of these big corporations. So it's hard to do, and it's even harder to hold on to people who can do it. Essentially, what machine learning is you feed various forms of data into a computer algorithm, and the algorithm gives you two types of predictions typically. It either gives you a kind of classification, so say something is or something isn't, or it allows you to regress and kind of predict. So in a sense, it's not that different to the statistical techniques that we already kind of know, like regression and perhaps factor analysis in terms of classification. So in this study, we trained the algorithm first by feeding it the colleague reports of GP's performance and letting it know how the humans had rated those reports, okay? And then what we do is we validate it on the kind of second half of the data set by feeding it reports of performance without telling it how they were classified by the human raters, letting it make its own classification, then comparing the classification between the two groups. And the way they were classified in this study was the reports were classified into a kind of theoretical framework decided by the human qualitative analysts to represent kind of being professional, being innovative, being respected, interpersonal, being popular. And it wasn't a very straightforward task, so the reason I kind of show this slide is to show that even though this is classified into the innovator, it didn't necessarily use the word innovator in it. So it wasn't a kind of very, very straightforward and simple task. It was quite complex. And the inter-rater agreement between the human and the computer was very, very high. And actually, we did some other analyses showing that you could get pretty much this agreement by just coding 250 bits of open text, which is probably less than an afternoon's work. So you can get a pretty accurate algorithm using very little kind of human time. And once the algorithm is trained, it can be applied to all the data you already have, and it can be used to monitor data that's kind of coming in a live fashion. So there's great potential, I think, here for making sense of open text data. And one thing we also wanted to look at is whether the things that the machine had identified could be used to kind of signal differences in GP's performance. So we found that if a GP was classified as being popular, then there wasn't any difference in their overall performance. So being popular might be nice for your, I don't know, coffee room breaks, but it doesn't mean that people sort of appraise you as being a more proficient, doctor, not necessarily GPs. There are all sorts of doctors in this study. The thing that really made the biggest difference in terms of signaling your performance was being respected by your colleagues. So if there was a signal in the text that you were respected by your colleagues, and you were likely to perform at a much higher level than doctors who weren't considered to be respected. And in fact, having any of these 5 classifications was also a significant predictor of higher performance, although at a lower level in this data set. So in summary, machine learning algorithms are eminently able to classify open text reports of doctors' performance. The accuracy, was higher than we would expect in a qualitative study. I think we'd normally settle with about 0.8 inter-rater reliability, so that was very high, even though the data set was reasonably small, and the way the features were extracted was could be improved. So there are better algorithms out there now. This is actually, in terms of machine learning, quite a out-of-date way of doing things. And that these classifications can signal significant differences in doctors' performances. I can see a future where these sort of things are collected iteratively, and that it's collected in a live way, and they can be used to kind of identify safety issues or concerns. Is kind of where I think these might be going. So the summary of the research so far is that computer adaptive testing is an acceptable way to make assessments shorter and more reliable, and to do so like quite impressively, up to 82%. And that machine learning can also be added to make sense of open text data and questionnaires. And our work going forward is going to be more about how we can quantify open text and calibrate it to a questionnaire. So the open text becomes something more like a question that you ask. So we can make even more sense of that. So that, I guess, brings us up in terms of what we're doing in terms of the cutting edge in psychometrics. And one thing we've been very aware of recently is this problem that there's the disparity between what we're capable of doing statistically and psychometrically, and what's actually deployed to benefit patients. There was this kind of tasty treat that's there, and people haven't been able to kind of reach it. And we kind of saw the solution is that we ought to be, as a centre, functioning to do the research, but also to focus very heavily on providing the tools and the training and the support to allow people to do these things and to implement these things. It's no good making a cutting edge software or a cutting edge algorithm if nobody has any clue of how to implement it. So this is something we've been focusing on very carefully recently, and is kind of we've come up to the 5th version of our software called Concerto. And Concerto is an open source tool for the development of online assessments that utilizes computer adaptive testing and tailored feedback, and is capable of having machine learning algorithms embedded in it. So this Concerto, I suppose, currently is run by kind of these sort of 6 people, some of whom have expertise in psychometrics, some in computational psychology, some in computer science, and some in statistics. So it's an example of how you need a very kind of broad group to bring these things together. We kind of realized that although IRT and CAT were described well in the 1960s, and there was perhaps a slight delay in the computer power picking up, but these things had never developed and they'd never been made widely available, because it's very hard to get a computer scientist and a psychometrician, and I guess a clinician, who kind of all speak the same language in the room. And Michal is really great at motivating people to do basically what he'd like them to do. So this is his project and his baby, really. So we have this vision that adaptive and electronic measurement should be available to non-experts. They should always be free, and it should always be open source. So it can be altered by anyone who wants to use it. It can be subsumed into other systems, and there are cancer registries in the US that are doing that right now. I think it's very important that, particularly in clinical practice, that the data and clinical kind of data security, that the data security protocol should be defined by the people who are doing it, which is possible under the open source. So saved on your servers, and data never go anywhere near University of Cambridge unless you'd like us to host it. And again, fitting with the slide with the young girl with the kind of chemistry kit, is that when expertise is needed, we should be ready to provide it as either consultancy, as training, or as kind of free guides online to kind of improve its uptake and the benefit for patients distally. So one thing I've found when I've been talking about this in the United Kingdom is that people are quite cautious about open source, that they feel like perhaps there's a catch. So open source is more than just something being free. I suppose it's more of like a philosophy of collaboration. So all of these products belong to companies who are doing very well. I mean, Tesla release all of their patents for no real benefit to their own company, other than this idea that they're being involved in a kind of positive net sum thing and can work on collaborations. So basically what we gain from deploying open source software is an increase in collaborators. So we have people coming to us and saying, I want to add this feature, can I add it? And then we can work together, and then our team can learn more, and the software gets better, and the end user's more happy. And that feeds back to kind of better brand recognition for us. It increases academic collaborations. People don't have to pay for these sort of things, and people don't stop to use the software because it doesn't do one important thing that they'd like it to do. You know, we can add that feature for you, or you can add that feature yourself. And of course, it does benefit in terms of paid consultancy and popularity for other products that are not open source. But we believe that by doing things open source, we end up with better products that are more widely used. And specifically in health, it's obviously very important that the patients benefit from this more than anyone else. So Concerto is kind of picking up momentum and is well used across the world. It's used in high stakes educational assessments in Australia where people use it. The National Board of, or the Regional Board of Studies uses it to give to school leavers to do a computer adaptive test that they can do any time and get feedback on. It's been used in clinical trials in medical schools across Europe and cancer registries that are putting it into their clinical electronic health records. And really the thing that we think distinguishes us from many other people is that it's completely flexible. You can choose the type of item, you can choose the type of test. It doesn't have to be computer adaptive, it can be a very simple short form questionnaire. You can choose how it's scored, you can change the feedback, you can change the way the data is stored so that some are accessible for clinicians, so a clinician can easily see what the data of their patients is, or you can anonymize certain bits of data or just take aggregate data into certain databases. You can allow people to log on using a national identity number or any other number that you kind of generate with them. We have a Facebook connection, which is perhaps less relevant for the interests in the room, but might be very interesting going forward. And there are APIs, so it can integrate with kind of current solutions for electronic health record management. And you can choose the data security and data storage based on where you install it. And you can install it lots of different places. You can install it on cloud servers, through Amazon typically. You can install it on your local server, which is what hospitals tend to do now. And via Docker, you can install it on your own private Windows PC, so no information ever leaves your PC. And as I've mentioned a few times, the rationale behind this is that the users can define their kind of data security. And also the speed and the data storage. So if you use an Amazon cloud server, you can have up to 1 million people, or I guess infinite number of people in theory, completing the test at the same time. So it's very scalable. So just to kind of compare the software that we produce with the assessment center software, which is also very good, but was limited, and the reason I started using Concerto in the first place was that it was too limited, that data had to be stored in the US, that you could only use the PROMIS questionnaires, whereas with Concerto you can use PROMIS and any other questionnaire you'd like to use. And the feedback I didn't consider to be ideal. So if you are depressed and you score very lowly on the depression scale, the feedback says you're more depressed than 99% of the population, and then that's the only feedback you get, which I thought was kind of fraught with danger if people are doing this kind of from home. Okay. So that's pretty much all the stuff I have to talk about in terms of proms, in terms of computer adaptive testing, machine learning, and Concerto. What I'd like to do is kind of talk about this other study we've been running at the University of Cambridge of how we've been able to predict people's personality from their digital footprint. It's perhaps less relevant for health now, but I think it shows what could be possible down the line when we can, have worked out how we can sensibly share people's digital information to help them benefit their care. So my personality was an example of big data analytics and social science using a personality questionnaire that a member of our centre had written, had put on Facebook and went viral and was filled out by something like 6 million people over the past 4 years. So we all know that big data is widely used and widely valued now by big business, particularly the kind of tech giants of Silicon Valley, but more often we're seeing sort of banks and other big businesses trying to leverage the insights that they can get. And Murdoch and Detsky, writing in JAMA a few years ago, said there's an inevitable application in healthcare, which I absolutely agree with. And the studies are just starting to come out, but it's a tricky space to navigate. So I thought the My Personality study was a good way of finding out what big data analytics using questionnaires or proms might look like. So the My Personality study was again created and hosted on Facebook, developed by the Psychometric Centre members. In this particular model, there was 3 million people who had completed the questionnaire and also shared all their public Facebook information, so not private information, but public information. And we wondered if we could build a psychometric model, not using questionnaires that say, I enjoy going to parties or I enjoy reading a good book, but by using the things that people were doing publicly on Facebook in terms of liking things. And it was quite a sensible hypothesis, I think. So if I like the Gothenburg University page, it's sort of like, you can see where I talked last time, sorry, that's quite embarrassing. That's sort of like answering the question, okay, but there's a lot more missing data basically in this scenario. Yeah, okay, so the My Personality paper came out a few years ago, and we found in PNAS, and we found that for certain things like your gender and your age, the ability to predict that was incredibly high, 0.93 for gender, and the ability to predict psychological traits in this first model was still quite high. And we've used this for some nice things since. So one thing you can do that is quite interesting is look and see which of the likes coming from Facebook were sort of the most predictive of different things. And actually the most predictive thing was for some reason curly fries for IQ. So people who liked curly fries for some reason had the highest IQ. And because this is a completely inexplicable finding, it got a lot of newspaper press and this sort of thing. And because of that, people started liking curly fries because it might make them smarter, I suppose. So on the next iteration of the model, it had kind of fallen out as a significant predictor. So another study done on this data by one of our PhD students last year, also published in PNAS, was looking at how well it works. So we invited 360-degree feedback on people and their personality, and we found that the computer's average accuracy was just a little bit worse than your spouse, better than your friends, your family, or your kind of work colleagues. So just from your public Facebook profile, you can make a very accurate prediction about someone's psychological profile. So this is my profile, which is charmingly a little bit younger than I am, apparently thinks I'm incredibly masculine. But in terms of my psychological profile, I think it's pretty accurate. And companies have been very keen to do this. So Hilton were interested in developing psychologically tailored advertising for their holidays. So you go on the Hilton app, and I'll show it you potentially later, and you log in with Facebook, it looks at your personality, and it sells you the holiday that it thinks you want based on your personality, but also that gives a text that is kind of commensurate with how you talk based on your personality. And just through this intervention that we tried out in the summer, they kind of increased the click-through rate by 7,000% or something. And I think this could potentially have a good application for patient consent forms, patient information leaflets, things that describe disease to people, the psychological tailoring of text. I mean, if it works so incredibly well for selling holidays, which we didn't know anything about before we started this study, then I think it also has great potential to kind of make health more engageable for patients. Okay. So I think some of the learning points, other than the kind of interesting way this was able to come about, was that millions of people submitted their data willingly and agreed to share it, and they didn't get any monetary incentive for this, they just got feedback. And I think that really demonstrates this point at just how much people want to learn about themselves. And if we have people filling out proms and prems, we really ought to be thinking about feeding this information back to them in a way that allows them to reflect and it is enjoyable. So we've planned some research to that end to see how feedback affects response rates, maybe improves reliability, because you're not just filling out some questions and sending it away, you're filling out some questions and then you get to see just how I'm doing or this sort of thing. Another good thing about the kind of open science and the open source thing is that all of these data, apart from the likes which we consented just for ourselves, are available free and to anyone. So there's a database of 7 million people's personality, and some depression and some sort of hypochondria scales that anyone can use, and we've collaborated with sort of 70 universities, and we've had 50 papers or so from this. And there's kind of no regrets from this very open model of kind of data sharing. Again, it's much more difficult if you were to do this with the kind of clinical population. But I think it's a nice example of collaboration. So this kind of inferential approach where we kind of take things that are happening and people are doing and we kind of infer psychometric scores from them might be really useful for the health sciences, particularly because data exists on a massive scale. Like, we can't do anything anymore without generating some data about ourselves that could be used to kind of benefit our care. So learning data cities are being planned where there are currently smartphone apps for patients with schizophrenia to report their symptoms in the community, which have been very beneficial. We're very interested to see if we can do real-time monitoring on patient movement and from their phones, some other things from their phone, how much ambient light is being received by their phone, the kind of noise levels, where they are, the environments they're in, and see if this can help identify people pre-relapse in psychiatry. And the advantage, of course, is there's no measurement latency, and it's pretty hard to kind of lie about it and tick the wrong box on purpose because you are aware that it might cause a certain outcome. So all of these things, Facebook likes, Twitter follows, images, we've successfully been able to predict people's IQ recently from their image, and a study from Harvard that came out just last week found that they could identify depression from Instagram photos better than clinicians could from speaking to people, without any kind of questionnaire or tool to kind of do that. So it's an important area. These kind of wearables are very popular and becoming more popular, so movement data, phone activity, interactions with friends. There's something called the Internet of Things. I'm not sure if you've kind of aware of this phrase. So the Internet of Things is this vision of a completely connected world. So sort of crazily enough, you can currently buy a fridge that you can text, and you can ask it how many beers you have left, and it will tell you, and it'll order more if you need them, or it'll kind of email you a recipe that allows you to cook all the things that are in your fridge. And I guess, like it or not, this is kind of the future we're moving towards, and all of these things collect data. And all of the people who make the things that collect the data want to know what to do with it. And it's, plenty of them are interested in using it to improve health because it's good PR for these sort of companies. So here's an example of the SF-36 that asks questions about walking more than a kilometre or half a kilometre. And I recently realised that I had sometime signed up to Google data which tracks my movement around Cambridge and knows exactly where I've been all of the time. But this sort of information could be so beneficial to a clinician for kind of tracking patients who might be at risk. So search terms, again, very obvious place for strong signals. So I guess these sort of Google search terms would be very indicative of these sort of prom questions. And in fact, Google have just recruited at the end of last year, Thomas Insel, who was the head of the National Institute for Mental Health. He moved to Google end of last year and said that technology can have a greater impact on mental health care than it can on any other diseases. And he wants to transform the area in the next 5 years. I wouldn't be surprised if, given all the data and resources that Google have and their desire to do massive things rather than just kind of small things, we see a big step change in patient assessment. So this is an important consideration that obviously we need to be thinking about, do people want us to look at this data? Is it an invasion of their privacy? And we've been kind of coming at this from a couple of ways. So we ran a study called the Predictive Data Project. We had over 30,000 people kind of complete these questionnaires, these questions which were related to how people felt about sharing their data and data privacy. So there was about 10,000 people who answered all of the questions. And in this sample, about 84% of people said that predictive technologies should be used to improve the quality of their healthcare. by helping doctors to recommend personalised sort of nutrition exercise plans. And another study conducted at a emergency department in the US found that 71% of patients were happy to share their social media information for their doctor, even though it wasn't for a specific reason. So they just said, would you be happy to share this if maybe we could improve your care with it? And it seemed like people were kind of happy for that. So that's just an example of perhaps where things are going in the future. So just to kind of conclude on everything I've talked about over the past hour or so, is that modern psychometrics offers loads of opportunities for improved clinical research and improved clinical practice and improved audit as well of services. That computer adaptive tests work really well in the real world, that they're here now, that the tools and technologies are there for them to be implemented, and we know they can benefit people. Predictions are something we can add, and that can engage people, and feedback can engage people, and they kind of enjoy that. And my personality showed what will be possible for inferential psychometrics and health research and the power of feedback in the future. I think this is an incredibly exciting field. It's exciting because it entails lots of cutting-edge technological developments, and all these things are directly for the benefit of patients, but also have great benefits across other aspects of comparative research and auditing. So we can get a lot of easy wins, I think, in the kind of same space using these techniques and these technologies. So thank you very much. My email's there. I'm very happy to kind of share the slides or answer any more questions that you might have. Thank you.